Good evening, and thank you for the opportunity to let me talk about such a vital topic, which invariably is so much prevalent in patients we deal every day. So, it's a topic on male LUTS, which means lower urinary tract symptoms, like the symptoms that the patient has related to passing urine. So we'll talk about overall what is LUTS, and also we'll talk about few drugs which are available which can ease the problem of the patient, and what are the other treatment modalities. So I'm Dr. Soumya Gupta. I am a consultant urologist. I'm attached to King's Hospital, Siliguri. So first, let's define what is BPH. BPH means benign prostatic hyperplasia. If I put it in a layman term, it means the increase in the size of the prostate, which is not associated with cancerous growth. So BPH overall is very much prevalent in the elderly population. So if we come to the definition part, it has a histological diagnosis. Histological means the one that is diagnosed under a microscope. We don't use these definitions while we talk to the patient. We just tell them that after the age of 40 or so, everyone's prostate shows a tendency of increasing in size. Usually, this increase in size is not associated with any kind of cancer, and we term it as benign prostatic hyperplasia. So, usually, this BPH affects the transitional and the periurethral zone of the prostate. Again, this becomes more of a uh, clinician's discussion than what we tell to a patient. In patient, we just tell them that the prostate increases in size, which compresses on the urinary passage, leading to his symptoms. So, prevalence, as I said, that BPH or the symptoms associated with the prostatic enlargement, they increase with age. You can see that there is 90% prevalence in patients between the age of 81 to 90. So this data has been taken from England, Austria, Norway, and India, and it represents the other countries in the world as well. So now, a very high prevalence of lower urinary tract symptoms is being noted among Asian men. And when we talk about Asian men, it means more towards India and the subcontinent, because of the lack of health infrastructure. Patients usually used to go undiagnosed. So, as I said, this is another graph showing that with increasing age, there is increase in the size of the prostate. So if a patient comes to me with LUTS, see, LUTS means lower urinary tract symptoms. Before I come to this, I need to talk about this slide. So LUTS can present as a voiding symptoms, storage symptoms, and the other associated symptoms. There is also another parameter known as PMB, or sorry, PMD, that is post micturition dribbling. What happens in the first one is the voiding symptoms. That means the patient will tell you that I have problem in passing urine, like my urine flow is interrupted. After passing urine, I still have the feeling that some bit of urine is left inside. I need to give some pressure to pass urine. So all these symptoms, like I go to pee, but I need to wait for some time before my urination starts. Everything falls under the voiding symptoms. That means the patient's complaint the patient has while he is trying to pass urine. The other symptoms is the storage symptoms. Storage means the patient has problem in storing the urine. That means in normal time, like now that I'm talking to you, in my bladder, it is the storage phase which is going on. That is, the bladder is storing urine. So If I have problem now, that means what kind of problem may I have while talking to you? That is, I might feel that I should go to pee. I should stop the slideshow now. I should go to pee. That is an urgency. And sometimes while I'm going to the washroom, I might leak. That is known as incontinence. So urgency and urge incontinence. At night time, when I'm supposed to sleep, that time I have to wake up multiple times to pass urine. That is known as nocturia. Previously, it used to say that means that the dictum was that you can two times at night if you wake up for passing urine, that's normal. But now it has been reduced to once. And another one is frequency, multiple times. I need to go multiple times to pass urine. So there is some problem with the storage phase of the bladder. That means the bladder is not able to fill up to its threshold and then give us a signal, go to the washroom and pass urine. Something happens before that itself, which triggers us to go to the washroom. The other symptoms are, like I said, post micturition dribbling. Patient might say that after I've passed urine, I wear my underpant, and within 5 minutes, I find that there's some drop of urine falling and which wets my underpant. So this is post micturition dribbling. So the other symptoms may be dysuria, hematuria, hematospermia. Dysuria means painful micturition. Hematuria means blood in the urine, and hematospermia means blood in the semen while ejaculation. So usually these associated symptoms are extra. We don't usually hold them or we don't usually consider them under the umbrella of LUTS. So we come back to the previous slide. So if any patient comes to me with lower urinary tract symptoms, so depending upon the age of the patient, we have lots of provisional diagnosis. If someone has lower urinary tract symptoms, it does not mean that it is the prostate which is causing problems. There may be other causes as well, which needs exclusion, like if there is overactive bladder. So this happens in patients with diabetes. This happens in patients with neurogenic bladder. Also, there is nocturnal polyuria. Few patients have increased urine production at night time. So this is a totally different pathophysiology, but patient will tell you, I need to pass urine several times at night. Then there is neurogenic bladder. As I said, if the patient has a bladder tumor, even that tumor can irritate the bladder and cause lower urinary tract symptoms. Also, patients with urethral stricture. Urethral stricture means that the urinary passage has a particular caliber. If the caliber of the urethra is compromised or it becomes narrow due to some pathology, that pathology may be several things. The pathology may be some trauma or prior catheterization with infection or prior history of gonorrhea and all. So this leads to narrowing in the caliber of the urethra, which prevents free flow of the urine out of the bladder, leading to the LUTS. Then there is the foreign body. If there is any foreign body inside the bladder, like sometimes what happens, patients on prolonged catheterization, some bit of the catheter tears apart or some rubber latex part tears apart and it stays in the bladder, causing irritation. Sometimes patients with a prolonged DJ stent also present with LUTS. So, and another one is prostatitis. If patients has infection of the prostate, that can also lead to lower urinary tract symptoms. So we'll go to pathophysiology. It's a huge topic in itself, but in short, we can say that usually it most important is the age. With age of the patient, there is increase in the size of the prostate, further relating the further making the patient prone to symptoms of LUTs. So another is the genetic factors. Few patients they say that my father or my uncle from the paternal or the maternal side also suffers from similar kind of symptoms. So some medical conditions like hypertension, diabetes mellitus, obesity, and increase in the lipid level in the body or increased cholesterol, increased triglyceride can also lead to increase in the size of the prostate. So there are few studies which say physical activity and alcohol intake decreases the chances of LUTS, but all these are not meta-analysis. These are few retrospective studies. So as I said, physical activity appears to reduce the risk of increased prostate and LUTS. Compared to no alcohol intake in moderation is associated with 35% decreased likelihood. Now, this is something which can send up wrong signal to the population. Why? Alcohol intake in moderation. What is moderation? No one knows what is moderation. And this is basically a study of retrospective and prospective studies. There is no systemic meta-analysis done which can give us a solid proof behind it. Okay, if some patient comes to us with symptoms of obstructive, that is, symptoms of voiding or storage LUTs, then the most important thing that we do is the most important is clinical examination. So we take a full medical history of the patient. What history? Whether the patient has any diabetes, whether the patient takes any drugs for hypertension. Sometimes what happens is there are medicines which we call it as diuretics. The physician prescribes diuretics to the patient, and the patient is taking diuretics, which leads to the increased frequency of urination. So even that can lead to LUTS. So all these histories are very important. We take history of whether the patient has been catheterized previously, whether the patient has any history of passing stone in the urinary passage, whether the patient has history of passage of blood previously, where the patient has history of constipation. Because if patients who have constipation, these patients have the tendency of incomplete voiding, has a tendency of frequency. So constipation is very, very important to be ruled out. Then there is a symptom score, which we call as IPSS. The IPSS is basically gives us a scoring. Like it divides every patient is asked few questions, and depending upon the symptom of the patient, we assign different score to the patient. Like 1 to 7, we consider to be mild, 8 to 19 as moderate, and more than 19 as severe LUTS. So IPSS is a kind of subjective questionnaire which is present with us, subjective assessment, which helps us in labeling a patient and assigning a score to the patient. Then it comes to the abdominal examination. In abdominal examination, what we see is if the bladder is palpable. Why? If the bladder is palpable, that means urine is already stored inside the bladder and is finding it difficult to come out. In that case, we need to think about putting the patient on catheter. We also need to think about whether the patient's kidney are at distress. Like if there is already urine in the bladder, which is finding it difficult to come out, so obviously the kidney usually lands up in hydronephrosis or hydroureter, which compromises the function of the kidney. Okay. Then comes a digital rectal examination. This is very, very important. In this, what we do is we insert our index finger into the patient's rectum and we examine the prostate. What we examine, we get an idea about the size of the prostate. We are not always sure about it. Usually there is 25% underestimation of the size of the prostate, but gives us a fairly good idea. Also, it also gives us an idea about the feel of the prostate. Usually the prostate is firm, but if it is hard, that points towards any malignancy or any chronic condition affecting the prostate. We also look for any nodules. Nodules also points towards malignancy or sometimes even benign condition like BPH also presents with nodules. So DRE gives an idea about the size of the prostate, also gives an idea about the anal tone. The anal tone means how much resistance my finger is having while introduction into the rectum. If we find the anal tone is relaxed, that means there may be some neurological problem as well. Neurological examination is usually not done until unless patient gives a history of any spinal surgery or any CVA or any kind of neurological conditions the patient is suffering from. So that the diagnostic test, the most important is to go for a urine routine. The urine routine, or we call as a urine analysis. This gives a very good idea, and the sample we take is usually a midstream urine. So this gives an idea about the whether the patient has any UTI, whether the patient has any kind of uh, blood in the urine, which is not visible to the naked eye, but visible in a microscope. Because then that points towards some stone disease also, which may also mimic LUPS. Renal function, usually not tested in every patient, but as I said, in abdominal examination, if the bladder is palpable, we check the renal function because the kidneys function may be compromised. PSA, PSA is something which is very controversial. Even the European Urological Association, they are constantly changing the recommendation for PSA. But now it is said that if there is a hard nodular prostate, if the patient's life expectancy is more than 10 years, then we may advise PSA. But if the patient is above the age of 70 and or the patient's life expectancy is not uh, is less than 10 years, then we can talk to the patient party. We can explain them that see there is a chance of CA prostate, but CA prostate, unlike other cancers, are not that aggressive. So since the expectancy life expectancy is less than 10 years, we won't go for any active management. Let's keep the patient on observation. And another most important is the ultrasound. Ultrasound with post-void residual urine. This is a very vital test. And ultrasound is basically a continuation of the physical examination. In ultrasound, what we have the idea is we can come to know about the size of the prostate, about the nature of the prostatic growth, about the amount of urine which is left behind after the patient has passed urine, about the condition of both the kidney, and also some other related associated problems like if there is any stone, if there is any tumor, everything can be screened using an ultrasound. So as I talked about the IPSS, which is a symptom score. So 0 to 7, it's mild, moderate is 8 to 19, and severe is 20 to 35. It is not always possible in a OPD setting to take a IPSS score of all the patient. But what we do is we take the help of a sister who is trained in this questionnaire. We give her this questionnaire. The patients are asked this question before the patient is visiting the clinic. He has a score with him. He comes, visit the doctor. We treat him accordingly. We call the patient up for a follow-up and follow up also with the IPSS score, and we check the score. If the score is decreasing, that means he's responding to treatment. So this is an overall algorithm, a flow chart, how the patient needs to be treated. So in short, the thing is, if the patient has mainly a storage symptoms, what we do is we put the patient up on lifestyle modification. Lifestyle modification means some patients, they have 5 to 6 liters of water per day. They have a bad habit of having excessive fluid at bedtime. So we tell them, see, this is not the way you need to do. You need to have 1.5 to 2 liters or 2 to 2.5 liters, depending upon the patient's age, other patients' comorbidities, everything. We restrict the amount of fluid. We also tell them that you should restrict your beverages, especially coffee and tea, to 2 times a day. Don't take excessive fluid after 7 p.m. in the evening. And after 7 p.m., if your throat is dry, try to have a little bit of water, which will moist your throat. While having dinner, if you feel as if some roti or some rice is stuck in your throat, just have a little bit of water just to swallow it. And at night time, if the patient needs to have some medication, then just that amount of water which is required to swallow the medicine. So Sometimes even 50 to 60% of the patient, they respond very good with just this behavioral modification, lifestyle modification. If the patient doesn't respond to this, then we have other drugs like antimuscarinic and beta 3 agonist. Both are wonderful drugs. Usually, the antimuscarinic used to be the choice, first choice. Now, because antimuscarinic has few side effects related to constipation or dryness of mouth, and especially in case of old age population, so that's why now the trend is shifting towards beta 3 agonist. If patients has a storage symptoms along with the voiding symptoms, then we can try the patient on some alpha blocker. Alpha blocker, as in alfuzosin, tamsulosin, silodosin. There are three drugs. There are others as well, which are not now used that regularly, but these three drugs are basically used depending on the patient population that we are treating. Now, in association with it, for storage symptoms, we may prescribe beta 3 agonist or antimuscarinic. If the patient responds well to the drugs, then we usually keep the patient on follow up with these medications and with an ultrasound and uroflowmetry or other test as per the patient. And if we find the patient is not responding well to medical therapy, then we need to think about some surgical management for the patient. So choosing the appropriate alpha blockers, see, the most important here is that what is the role of alpha blocker? So the alpha blocker basically relaxes the smooth muscles in the bladder neck. So it has just this function, which is important. If you see the normal thinking, means the thought process of the patient is that this is a medicine which is associated with prostate. No, it has nothing to do with the prostate. It is basically the medicine acts on the bladder neck and the prostatic urethra on the alpha blockers or the alpha 1 receptors. So there are other drugs as well, like 5-ARI inhibitors, like we have tadalafil and all these drugs. But for LUTS, alpha blockers are still the first line treatment. 5-ARIs are used if the patient has associated erectile dysfunctions. But the LUTS in actuality is basically treated with alpha blockers. So, as I said, there are lots of alpha blockers in the market, but the most commonly used are alfuzosin, tamsulosin, and silodosin. So they act on the smooth muscles of the prostate and the bladder neck, relaxes it, and allows the urine to flow out of the bladder. So sometimes this alpha blockers also reduces the storage symptoms of the patient. So, but this alpha blocker can give the patient lots of improvement when it comes to LUTS, but has no long-term effect on the risk of acute urinary retention or any BPH-related surgery in the future. So, which alpha blocker and why? This is most important. So, as I said, alpha blockers are basically well tolerated. So, but it has some associated side effects. Like uh, if the patient is associated with some very heavy work or walking in heights and everything, I usually advise them that you start with the alpha blocker on Fridays, on Saturday, so that you can stay at home and you see whether you have any side effects which can affect your daily activity. So the timing of taking it is always at bedtime. So the symptoms are headache, dizziness, postural hypotension, nasal congestion, and retrograde ejaculation. But retrograde ejaculation is more common in tamsulosin and in silodosin. It is not that common in alfuzosin. So, as we see in this chart, that tamsulosin and silodosin both causes retrograde ejaculation, which is not present in patients taking alfuzosin. So, making alfuzosin the treatment of choice in sexually active patients with LUTS. So another thing is that patients usually they are distressed if you don't counsel them while giving tamsulosin and silodosin regarding this retrograde ejaculation. They will come running to you the next day or day after, telling that this is the problem and this retrograde ejaculation, all these are private matters. So obviously they can't share it with any other person as well. So they are always in a distress. They think there is something wrong with them. They'll come to you. So that is why, just to decrease this anxiety, so you just need to counsel the patient beforehand that, see, this might happen, and there is a stigma, or there is another, we can say, there's a thought, there's a something which is embedded in our Indian population or Indian doctors also. We feel that if a patient is above 60, this retrograde ejaculation is not that important. So no, it is important. It is important for everyone. It is important irrespective of the age. Every patient has a right to have a normal ejaculation, irrespective of the age. So even if the patient is 70, even if the patient is 72, 73, 75, above 60, you need to counsel them about the chances of retrograde ejaculation. So, but that is not present with alfuzosin. You need to tell them that alfuzosin, tamsulosin, silodosin, these are the three drugs. Tamsulosin, silodosin are basically more selective. That means overall side effects of dizziness and this postural hypotension are comparatively less with tamsulosin and silodosin, but still it may happen with you as well. And we also ask them, is irrespective of the age of the patient, that are you sexually active? If they are, then it is better to go for alfuzosin over tamsulosin and silodosin. So any additional treatment or additional side effects that we have is, this is known as floppy eye syndrome, uh, floppy iris syndrome. So this is basically, uh, what I'll say is that it is limited to the books in most of the cases. It happens with the alpha blocker treatment, especially with tamsulosin, less with silodosin. So what we do is not usually practiced by urologist, but still I'm telling you, what we do is, we just, while doing the regular examination of the patient, we just check whether the patient has any cataract. We ask them that whether they have difficulty in their vision, if they have difficult, or they're planning to undergo any kind of treatment for their cataract. If they say yes, we are planning to get treated for cataract, it is advisable that you don't start alpha blocker. You ask the patient to go to the ophthalmologist, get the cataract treated, and then you come over, and then we start with the alpha blockers. If the patient is in distress with related to this urinary problems, we can put him on catheter and let the whole cataract treatment get done, and then we can start with the alpha blocker. But if the and or if the patient says that, no, I don't want to go for cataract surgery as of now, then you can start with alpha blocker. The problem is this, that even after discontinuation of the alpha blocker, this floppy iris syndrome may occur. So there is no definite time duration that you need to stop this alpha blocker this months before surgery. No, nothing. Even if you stop it, you're not sure that you will prevent the floppy iris syndrome. So comparing alfuzosin with on ejaculatory functions versus tamsulosin, as I said, that basically the end point is to have a antegrade ejaculation, which is something alfuzosin provides. Tamsulosin, silodosin usually causes retrograde ejaculation. So tamsulosin result in significantly decreased ejaculate volume compared to the alfuzosin or placebo. So another thing, very important message from here is, sexually active males with LUTS, and we have ruled out the other causes of LUTS, then we can think about alfuzosin. And if the patient is opting for no, if the patient says no, you can give me tamsulosin, silodosin, then kindly explain the patient that, see, you might have this retrograde ejaculation, so don't get worried about it. So same thing over and over again, sexually active male LUTS patients, always advise alfuzosin. So just an example with a case. This case is of a 65-year-old male. Say, remember here, 65. So first thing that goes in our mind is 65 years, almost retired person, maybe sex is not that important, or sexual intercourse or sexual desire is not that important. But it is not that. Even if the patient presents with frequency, urgency, dysuria since 6 months, you see the IPSS score is 20 out of 35. That means severe. So this patient requires some kind of treatment in the form of drugs or in the form of surgery if the drugs does not work for the patient. So is sexual history important in this patient? Absolutely. It is important for all kinds of patients, every patient, irrespective of the age of the patient. So these are all the tests that we have run. It was a grade 1 prostate, smooth prostate. Other tests were more or less okay. So in these patients, which alpha blocker you should use? Yes, you should always use alfuzosin because the patient is sexually active and desires to retain this sexual activity. Always remember, alfuzosin does not cause any erectile dysfunction. In fact, there is some study which says alfuzosin also improves erectile dysfunction, but the problem is with ejaculation. Patients have lots of different psychologies. Few patients feel that if the ejaculation or the ejaculate or the semen doesn't come out, I'm not satisfied, or there is something gravely wrong with me. So alpha blocker. So which alpha blocker? Alfuzosin in a sexually active male. Anticholinergic required or not, as I said, the patient has frequency urgency, but most of the cases, alpha blocker itself can treat the storage symptoms. But if with alpha blocker also we find that there is persistence of frequency or urgency or urge incontinence, we may add a anticholinergic or beta 3 agonist. Again, I said anticholinergic causes constipation or dryness of mouth. So we need to ask the patient whether he is already prone to constipation, whether he is whether he's taking some medications, neurologic medications which predisposes the patients to constipation. So in those cases it is better to avoid anticholinergic and to go for beta 3 agonist. So we started the patient on alfuzosin as the patient was sexually active. The patient did not improve. Mirabegron was added. Mirabegron is beta 3 agonist. So the most important point here is that alfuzosin in itself can treat the storage symptoms in most of the patients. If some storage symptoms still persist, which is hindering the normal life of the patient, we add a beta 3 agonist. The patient improved and is on follow up. So overall, the thing is that if the patient is not sexually active, silodosin or tamsulosin may be our treatment of choice. So, but if the patient desires, then we'll go for tamsulosin. Thank you so much.